Hi, my name is Gina Cannon, and I'm a nursing student on the Beach Unit. I'm going to present a patient to you right now. Patient is a 69-year-old widowed Caucasian female. Current occupation is retired, and her usual source of medical care is her primary physician. Patient was transferred from St. Joseph Mercy Hospital and admitted to Heartland Healthcare Center in Ann Arbor on August 1, 2014, for recovering and strengthening from post-cardiac surgery. Due to complications resulting from the procedure, patient is also here to treat speech and language aphasia and to redevelop cognitive skills. Because of patient's aphasia, much of this information was taken from her charts. On August 1, 2014, patient underwent cardiac surgery for mitral and aortic valve replacement and patent foramen ovale closure at St. Joseph Mercy Hospital. There were no determinants for the mitral valve disease and aortic valve disorder, so onset occurred over time. Patient doesn't currently state to be in any pain, although an associated symptom includes a right hemiparesis and aphasia consistent with the left middle cerebral artery distribution stroke. Patient needs assistance with all daily activities, but is cooperative and responsive when encountered. Pharmacological and non-pharmacological interventions include hyperlipidemia and hypertension medication, rehabilitative exercises, and cognitive and social stimulation. Patient has stable vital signs with a heart rate of 72 beats per minute, blood pressure of 142/65, temperature of 37.5 degrees Celsius taken orally, oxygen saturation of 98% on room air, and respiratory rate of 33 breaths per minute. Past medical history: chronic hypoxic respiratory failure, acute pneumothorax, pulmonary edema, dyspnea, hypertension, acute kidney injury with creatine at 1.19, valvular disease, hypercholesteremia, metabolic acidosis, hyperkalemia, urinary tract infection, depression, class 4 congestive heart failure, stroke, esophageal reflux disease, severe chronic obstructive pulmonary disease, right eye blindness, degenerative joint disease, and scarlet fever at age 5. All immunizations are up to date. Allergies include penicillin, contrast dye, aspirin, codeine, shellfish, latex, iodine topical, and cortisone. Exposure to any of these would result in anaphylaxis. Past surgical history: craniotomy, cholecystectomy, appendectomy, oophorectomy, hysterectomy, and hemorrhoidectomy. Patient is on numerous medications for hyperlipidemia, hypertension, acid reflux, and depression. Patient takes 40 milligrams of atorvastatin calcium tablet by mouth with dinner, a 75 milligram clopidogrel bisulfate tablet by mouth once a day, 125 milligram carvedilol tablet by mouth 2 times a day, and 130 milligram lisinopril tablet by mouth once a day, 120 milligram famotidine tablet by mouth every 12 hours, and 140 milligram fluoxetine HCl capsule by mouth once a day. Functional assessment: patient denies current alcohol, tobacco, and illicit drug use. Patient claims she exercises 3 times per week throughout her occupational therapy at Heartland. It denies any sleeping problems, eating difficulties, and caffeine intake. Patient states she used to smoke 2 packs a day for 34 years, but quit in 1998 after her husband passed away from a lung condition. Psychosocial: patient is single and lives alone, and her closest family member is her sister who lives in Saginaw. She has many grandchildren and grandnieces, although she isn't able to see them often. Though patient has depression, she appears to be positive and cooperative to whoever is speaking to her. Patient claimed to graduate from high school and practices Catholicism, though she has been unable to go to Mass in a while due to her cardiac procedure. Coping mechanisms include exercise, reading, and crossword puzzles and word searches. Family history: patient's mother, father, and grandmother all had coronary artery disease, and her sister had an aortic aneurysm. Patient states both her father and brother passed away from a myocardial infarction. Cardiovascular: given the patient's cardiac procedure, it is important to assess her strength and recovery every shift. Patient denies any chest pain, heart murmurs, palpitations, or orthopnea. Patient claims to have right arm numbness, hypertension, and more fatigue than usual. She states she can walk about a half mile before becoming distressed. Patient claims to use 1 pillow when laying flat and that she fatigues every 2 hours. Upon examination, patient's chest contour is flat, though has a vertical scar from her sternotomy. No heaves or lifts were detected, nor lifts or thrills palpated over the 5 key areas of the heart. The PMI was palpable at the left midclavicular 5th intercostal space, an apical pulse with 72 beats per minute. Upon auscultation, the aortic, pulmonic, Erb's point, tricuspid, and mitral areas were assessed with both the diaphragm and bell, and with the patient both supine and sitting up. In both positions, S1 and S2 sounds were auscultated over the 5 key areas of the heart, and no S3, S4, or murmurs were appreciated. S3 and S4 sounds again were not present when auscultating with the bell, and patient was lying on her left side. Neurological. Given the patient's sudden right hemiparesis and aphasia consistent with a left middle cerebral artery distribution stroke, it is important to assess her speech and language therapeutical progress every shift. Patient denies having any numbness, tingling, burning, or insomnia. Patient claims to have had a seizure, yet denies having epilepsy. She denies any concerns about memory and ability to concentrate and claims to enjoy reading. Patient claims to be unsteady and needs assistance getting around, and that anxiety sometimes interferes with her daily activities. She claims to have trouble with speech and is upset when she cannot enunciate properly. She claims to have had a head injury when she was 18 years old due to a car accident. Upon examination, patient is in no acute distress lying in bed, and appearance is well nourished and adequately groomed. She appears her stated age. Patient is alert and oriented to person, place, and time. Speech is not clear, though pace is not too fast or slow. Facial expressions are present, and attention span, long-term and short-term memory are all intact. Abstract reasoning, judgment, intellectual ability, and thought processes are appropriate and present. Because patient was in a wheelchair, neither gait nor the Romberg test was assessed. However, both upper and lower extremity fine motor function was present. Light touch, vibratory, and pain sensations were not assessed as tools were unavailable to do so. Cortical and discriminatory sensation was present. No ankle clonus or Babinski reflexes were detected. Pertinent system number 1, respiratory. Patient was diagnosed with COPD, chronic respiratory failure, and has bilateral bronchi within her lungs. According to the American Lung Association, COPD is the 3rd leading cause of death in the United States. It causes serious long-term disability, and at this point in time, there is no cure. Smoking is a major cause of COPD as poisons in the cigarette weaken the lungs' defense against infections, destroy alveoli, and narrow air passages. Deaths due to COPD are higher in women than men and have increased 4-fold over the past 3 decades. Given my patient's gender and history of smoking, it is necessary to evaluate the function of her respiratory system as she undergoes COPD herself. Symptoms of COPD include dyspnea, frequent respiratory infections, cyanosis, fatigue, wheezing, and a chronic and productive cough. These symptoms are typically not experienced until later stages of the disease. Treatments are available, though because there still is no cure, it is important for patients to avoid waiting for symptoms to become severe and irreversible. Pertinent system number 2, musculoskeletal. Patient was diagnosed with degenerative joint disease, commonly known as osteoarthritis. Osteoarthritis patients experience joint pain and stiffness most commonly in the distal ends of the fingers, the thumbs, neck, lower back, knees, and hips. It typically develops over years and affects everyone differently. Some may have relatively mild pain that interferes little with the day-to-day life events, while others may have significant pain and disability. In many patients with osteoarthritis, effects are not only physical, but lifestyle and finances decline as well. Given my patient's age and diagnosis of osteoarthritis, it is imperative to give her a musculoskeletal assessment to determine the severity of degeneration and create goals for pain reduction. Common approaches to treat osteoarthritic pain include exercise, weight control, rest and relief from stress on joints, non-drug pain relief techniques and alternative therapies, medications to control pain, and surgery. This assessment is critical for my patient because more information gathered on her current range of motion at various joints will allow a better assembled care plan for her to live a healthier and more comfortable lifestyle.